research looks at point-of-care creatinine technology and how we might use it in radiology to streamline our pathways for patients undergoing CT and MRI scans with X-ray dyes. The use of X-ray dyes for CT and MRI scans is quite standard. Although they're associated with a low risk, there is the possibility that we can induce some contrast-induced acute kidney injury, and this is related to renal function. The risk is a lot higher in patients who have an established renal insufficiency or certain risk factors such as heart failure and diabetes.
Hello, my name's Bev Snaith. I'm a clinical professor of radiography both at Yorkshire hospitals and the University of Bradford. So I was chief investigator in the series of projects looking at point-of-care creatinine for patients undergoing CT and MR scans. When we first initiated the project, we made contact with the NIHR Diagnostic Evidence Cooperative at the University of Leeds. They suggested that we made links with the AHSN because they were about bringing together industry, academia and the NHS. That provided us a really fruitful development. It allowed us to link with new patient and public involvement teams as part of our steering group. It also provided us some relatively small funding to initiate our first project. Their key role was actually in linking with industry.
National and local guidance currently states that all patients who are having X-ray dyes as part of their radiological investigations must have a blood test from the 3 months prior to their scan appointment so that we can provide management for patients who do have renal insufficiency prior to the administration of X-ray dyes. Following a national survey that we undertook, looking at how other departments are obtaining blood tests for CT and MRI patients, we decided to undertake a programme of research that looked at not only how does the point-of-care creatinine technology perform against the standard blood test, but also how do we implement it within our radiology pathways to ensure that we not only minimise risk to patients who are undergoing CT scans and MRI scans with contrast, but also improve their experience. Currently, if patients attend for CT and MRI scans for scans with X-ray dye and they haven't had a recent blood test undertaken, we are unfortunately unable to take the test. We can perform the scan without any X-ray dyes, however this reduces the diagnostic yield of the resultant scan. By implementing a technology that would allow us to test patients on the day, we are not only maximising their renal safety, but also it ensures that we are using the scanner efficiently and that patients' appointments aren't cancelled on the day. It would also avoid patients having to have extra appointments at hospitals for blood tests only. By being able to do it on the day, we could make sure that they potentially have direct access to scans.
Our link at the AHSN was Carl Greatrex, the innovation lead. It was key in developing our links with industry. He negotiated contracts and the loan of machines and consumables from 3 point-of-care providers, ensuring the project happened at relatively low cost but in an appropriately supported way. He then continued to link with us in terms of a steering group member, challenging how we would develop and deliver the project, particularly beyond the research itself.
So we've undertaken 2 projects so far. These are single centre studies. The first study looked at the concordance of the point-of-care creatinine test to the standard laboratory blood test in 300 patients attending the phlebotomy clinic. These patients very kindly allowed us to take an extra blood sample which was tested on the point-of-care machine, and we've looked at how that relies against the standard blood test. In the second study, we then moved this testing into radiology to look at our population and whether implementing this technology would benefit our patients and how we might implement that technology within our pathways. Following the success of these 2 first research projects, we aim to test the point-of-care creatinine technology on a multi-centre basis within radiology departments to find out whether implementing this technology will benefit patients on a larger scale across the NHS. Funding for this research will be sought in the future. In the second study within radiology, as well as looking at how the point of care technology performed against the standard blood test, we have also fully mapped the CT pathway for cancer patients to identify where efficiencies can be made and the economic impact of point of care technology within the radiology department. As well as the Mid-Yorkshire Trust, we've also mapped the pathways across other acute trusts in the region to ensure transferability of research findings.
Our research will live beyond these two projects, but our links with the AHSN will continue both in terms of local and national projects. We understand the transferability, implementation and development of innovation requires links between academia, clinical and industry partners. As a clinical radiographer, it's very difficult to engage with industry directly, and actually having the AHSN as a core member of our team was absolutely valuable, and I'd recommend that to any researchers initiating similar projects in the future.